ER for 8 hours because I didn't realize that this was, you know, a side effect of some other medication I was taking, or something that you guys knew would happen but didn't tell me about, so I didn't know that I should, how I should respond to it. And then bereavement care. And so what I've got over here, this is one of my favorite quotes from Harry Potter. So words are, in my not so humble opinion, our most inexhaustible source of magic, capable of both inflicting injury and remedying it. So I think about this all the time, especially when I hear something said to a family and then I watch them respond, you know, and maybe somebody said, you know, you just tell us when you're ready to give up, and I see them, you know, dig in, and I think, oh, okay, we're going to have to go back and address that so that that gets smoothed over. Or maybe somebody says, I'm trying to think of what the other thing a family said to me recently. Oh, your kid isn't going to live long enough to have that problem anyway, you know, and the family had this bad reaction to it, and I thought, okay, we have to go back and figure out what's a better way that we could have said that. This is another picture of perinatal care, and what's going on here is this infant was just born. Again, one of the things that was important to this family was for their infant to be baptized. So this is one of our chaplains, Noel, doing the baptism for this family in the delivery room. And then this is a picture from Joanne Wolfe, New England Journal of Medicine article, about the % of children who report different symptoms at end of life. So fatigue, like 95%, pain and dyspnea are about equal at 80%, anorexia, nausea, constipation, diarrhea. So pretty high symptom burden reported by children. This was specifically children with cancer. And then doing some legacy building and memory making. And at our hospital, Child Life and Art Therapy and other groups are really good at doing this in a way that allows it to happen over time. So lots of times we're thinking, hey, Christmas is coming up, you know, let's make something together for your mom. So then maybe mom has something, you know, like handprints or a special video that their child made or a song that they sang for them. While their child could still do it, that is going to be important to them for the rest of their lives, whether their child makes it past Christmas or not. So those are some of the tasks of palliative care that we all participate in together. So I want to share a couple stories with you. So this is Maggie, and Maggie is a girl who I met when I was in residency training. And when we would talk about goals with Maggie, one of her goals was to be a teacher and to let other people learn from her experience, and so I like to honor her by continuing to do that. So I met her when she was 12. She had Behçet's disease, which is an autoimmune disease causing multi-organ failure over time, and we were treating with steroids and with immunologic agents, but it was becoming clear to us that it didn't seem to be making much of a difference, and we felt that if we stopped them, there was a high likelihood that she would die, but we weren't actually sure that she would live longer with the treatments. And her parents wanted her to be able to give input into the treatment plan, given the poor prognosis and the uncertainty ahead, and the fact that she had always been very invested in her own treatment in the past. So this is a picture of her when she was younger. I don't remember exactly how old she is in that picture, but I think she's got a cast on her leg. One of the issues was osteopenia, so she had broken many bones. And then this is a picture of her when I knew her. You can see the effects of the steroid treatment on her, and yet she was pretty much spending all of her time in the hospital because we just really couldn't get this disease under control. And so this is a picture of her mom and her doctor and her nurse coordinator, who's one of the palliative care nurses, talking with Maggie about what the treatment options are. And Maggie came up with a bucket list of things that she wanted to try and get done with whatever time she had left. And then we had some challenging conversations about everything from stopping treatment to code status. And she taught me how not to have a code status discussion. So I'm pretty sure that we went in and did it the way that I had always seen it done, which was to say, you know, if your heart stops, do you want us to try to restart it? You know, if you stop breathing, do you want us to help you by putting a tube down and connecting you to a ventilator that will breathe for you? And she looked at us and she said, yes. So why did she say yes? Yeah, she doesn't want to stop breathing and not have anybody help her, right? We didn't actually give her any other option. It was like, do you want this or do you want nothing? Ooh, my other pet peeve. Like, do you want treatment or do you want nothing? I'm like, palliative care isn't nothing. It's actually really good, supportive, you know, comfort-focused treatment, but somebody has to describe it. So we didn't think that we had explained it adequately to her, so we did it again. We said, okay, you know, if your heart stops, which would mean that you're dying and that your body is trying to tell us that it's done, you know, do you want us to do chest compressions and try and keep it going longer, or do you want us to keep you comfortable and make sure that your mom can be here to be with you during that time? And if you stop breathing, you know, do you want us to put a tube in and breathe for you, or do you want us to keep you comfortable? And she's like, well, keep me comfortable. Isn't that what we've been talking about? And it was like, oh, yeah. I think so. So how we talk about these things makes a big difference. And in a patient that I was helping out with in the PICU the other day that is presenting a lot of ethical challenges, you know, her mom wanted to do a trial of extubation. So we did a trial of extubation. It was not going well. You know, everybody was giving input. So Howard, the RT who was working with us that day, you know, was telling us what he was seeing from his end about secretions and how she was doing managing things and what kind of edema and flow he was noticing. And she was just, it was clearly very uncomfortable for her to be extubated. And we had talked about it beforehand, and Mom had said that she would want her to be reintubated, but we'd also talked about the possibility of following her lead and letting her show us, you know, what she wanted. So at least in the moment we offered. We said we can reintubate like we planned on doing, or if you want, we can focus on keeping her comfortable, giving her some medicine so that she's not working so hard, and letting her kind of take us on this journey. Mom wanted to reintubate, so we reintubated, but we almost didn't even give her the other option because I think we're sometimes so reticent to say it. But just saying it, you know, puts it out there as something that somebody could legitimately accept for themselves or their loved ones, but we have to describe it in a way that makes it acceptable. So Maggie was able to go to a lot of hockey games, spend a lot of time with her dog. We had an early 13th birthday for her because she wanted to be a teenager and we weren't sure we were going to make it. So we crossed off as many things on her bucket list as we could, and she died peacefully without us doing anything additional to her, you know, that wasn't really for her. So I like to share a list of questions because I think one of our tasks in healthcare is to tell people what we can do for them, but another is to listen to them and find out what's important to them and what they want out of their healthcare. So these are from Atul Gawande. He is a surgeon. He wrote the book Being Mortal. He also wrote Complications and some other book that I can't remember the name of, the Checklist Manifesto. So he's a writer and a surgeon, and he sort of discovered palliative care and realized, wow, this is good stuff. We should be helping people get the best out of life and not just doing things to them because we can. So he wrote the book Being Mortal and also a New York Times article, The Best Possible Day, which is a little shorter if you want a shorter read. But his sort of key questions are finding out what's your understanding of your health or condition. What has this journey been like for you? How are things different today than they were, you know, a week ago or a month ago or a year ago? What have your doctors told you to expect in the future? What did the last team who came in talk to you about so that I know where we're starting from? What are you hoping that the treatments will do for you? Because that can tell us a lot. And sometimes when I've asked a question like this, I find out somebody's a lot further along than we've been giving them credit for. So the family might say, we know she's going to die from this, but we're hoping for as much time as possible. okay, we didn't even know that they knew she was going to die from this condition, and yet, you know, they were able to tell us that. So finding out where they're from without just sort of assuming and starting talking is a great idea. And then what are your goals if your condition worsens? I'm really good at asking what are your goals. I'm not as good at asking if your condition worsens, which is kind of the key to find out, you know, what next steps should we be thinking about in kind of advanced planning. Every family I ask, if I ask this question, you know, what are your goals for their child to live, to be as healthy as possible? I don't think any parent could, you know, not have that be one of their primary goals. But what else are you hoping for? Or what else is important to you allows them to tell us things like, well, he really loves being at home and hates being in the hospital. So if we could get back home, that would be really important to us. Or he's really been uncomfortable from this symptom. If we could get that under better control, that would make his life so much better. So it allows them to share their other goals without necessarily starting there. So asking what else is important, what else are your goals, what else can we do? And then maybe thinking about trade-offs. How does being comfortable or being at home compare to staying in the hospital and having this treatment for longer? Because sometimes we present it as staying in the hospital and having a treatment for longer is always better from our perspective, which it's not. So we want families to know that they can weigh those things. And then what are your fears, your worries, your concerns? This is where people might tell us, I'm not afraid to die, but I'm afraid of dying. Like, I don't want to suffer. I'm afraid of what it's going to feel like, that I might be in pain, that I might be alone. And then we can try and alleviate those fears to make dying go better for them. What are parents afraid of for their children? That they'll suffer, that they'll feel alone. So can we alleviate those fears? Sometimes they're things that we have a simple fix for. Sometimes they're existential questions that we just have to listen and be present with them for. What are trade-offs you're willing to make or not make? And one way to think about that is, what are you willing to live with? Are you willing to live with a trach and event in your home and home nursing? Are you willing to live with a 2-week hospital stay to have a spinal fusion? Are you willing, you know, what are you willing to live without? You know, are you willing to live without having tried this treatment, you know? And that really is helpful for families, because sometimes they'll think, you know, I can't live thinking that I did this to them and they died anyway. But for another family, they might think, it will be harder for me if I didn't try this. So figuring out, you know, where they're thinking along those lines. And then communicate clearly and compassionately about achievable outcomes. So what do we think is actually achievable? There's usually a range. We don't have crystal balls. We can't predict things. But families really like it when we give them at least our best guess of what the range is, from worst case scenario to best case scenario, and what the most likely scenario is. That's how I often try to present it. What's the worst case? What's the best case? What's my best guess of the most likely? And using phrases like, I hope, but I worry. That allows me to align with their hopes that this treatment is going to work well for their child and they're going to improve. But I worry, and then maybe you could share, because, you know, this treatment isn't designed to cure. You know, some cancer treatments aren't designed to cure. They put things at bay for a while. Or I worry because she hasn't responded the way we hoped thus far. So we're giving them information, but in a way that really shows that we care about what's important to them. And another phrase is, I wish, I worry, I wonder. So I wish that we had another treatment available. You know, I worry that even if we did, we might be doing things to her that are no longer helpful. You know, I wonder what else we could do to make this time as meaningful for your family as possible. And then give your best estimate of possible outcomes. So sometimes that's time ranges. Are we in the days to weeks? Are we in the weeks to months? And sometimes it's functional outcomes. Okay, So what parents want is honest information so they can make good decisions, even if it's difficult, and then also the time to process, discuss it with their families, and figure out what to do with it. They want ongoing relationships with trusted providers, and they want to be able to continue to provide love, hope, comfort, and care to their child, to be seen as a good parent and to feel like they did everything that they could. They also want some privacy and a sense of security for their family, and to be able to make decisions for their child but not feel like every decision rested fully on their shoulders, especially to have us say, when do you want to quit, sort of question. So what we can shoulder from that is sometimes not offering something that we don't think is a reasonable treatment at that point. You know, if it's not reasonable to escalate care, then we shouldn't offer it and then hope that the family turns us down. But one tool to